Good afternoon, everybody. Please be seated and try to come in the first row and the second. My name is Viêt and Nguyen-Thanh. I work for Santé publique France, and I'd be delighted to co-facilitate this session with Caitriona Reynolds, who is in charge of social inequalities in the Irish Health Service Executive. So it's basically Public Health Ireland. So thank you very much for choosing this breakout session. It's the continuity of yesterday morning's plenary. Maybe you were here. It was organized by Jennifer Davis and Pierre Arwidson of the Health Promotion Department of Santé publique France. And without any further ado, I'd like Mr. Pierre Davidson to join us on stage for a quick opening remarks that will connect with the plenary of yesterday.
Bonjour à tous.
Good morning, everybody. I would also like to thank Laetitia Huillard for her support and help, but also the entire organization committee, the communications department, and of course the Formule Magique event organizer that runs the show. So with Jennifer, we've collaborated to organize this session. Now, Jennifer did 99% of the work, and I did maybe 1%, probably less than that, actually. Now, I'd like to go back over some historical milestones on experimentation in behavioral sciences. So let's start about the beginnings. The very first clinical trial was about the prevention of a disease. So James Lind had tried several remedies against scurvy, like sulfuric acid, cider, vinegar. And then the first random assignment clinical trial was in 1898 by Johannes Andreas Grib-Fibiger in Denmark. He worked with diphtheric patients who were alternatively assigned to different groups depending on the day of their admission. But then there was a lot of resistance to the random approach. So why so much resistance? We're here in the 19th century, because this method questioned traditional methods, and also clinical specialists did not want to embark upon random therapeutics. In the early 20th century, there were many new drugs and really extravagant claims from pharmaceutical firms that were exposed by journalist Samuel Hopkins Adams in a book published in 1905. This prompted public authorities to pass regulation in America, in England, many other countries. So they introduced the pre-marketing approval. Now, if we look at behavioral sciences, so here we have Kahneman and Tversky, but actually we should start much earlier. Actually, behavioral psychology was created in 1913 by James Watson, a researcher, so that was 111 years ago. And Dr. Watson wanted psychology to become scientific, and that experiments should be based on observable facts and not on things happening in people's minds, and that therefore could not be observed. So Kahneman and Tversky were psychologists. This is a 1979 article, a paper that you can see on screen. So originally, this work was categorized as cognitive sciences, and that's how I came across this work in the 1980s. And they found that the human reasoning was not optimal and not predictable, and that people's choices were depending on what was presented. So where they were nicknamed the Lennon and McCartney of social sciences because they really revolutionized the entire field. Now here are the 3 Nobel Prize winners in economics. so who worked in behavioral economics, Daniel Kahneman. I've just mentioned him. He was awarded the Nobel Prize in 2002, and I think we can pay tribute to him because he actually passed away in March 2024. And just for the record, Daniel Kahneman actually first spoke French because he spent his childhood here in Paris. Then Richard Thaler, who was awarded the Nobel Prize in 2017, he's famous for his book on nudges. And yesterday, David Halpern showed us a photograph of him and Richard Thaler in front of number 10. And here, the French Nobel Prize winner, Esther Duflo, was awarded this prize in 2019. And yesterday, Marc Bardou told us about how he discovered Esther Duflo on the radio, all her work, and he told us then about the ensuing collaborations. Now, I don't want to spend too much time on this, but let's come back to Daniel Kahneman. I've just paid tribute to him. Daniel Kahneman really tried to simplify and popularize this field of study, saying that human beings have an automatic, energy-efficient system. So specialists review what comes to mind, so that's the dominant method, and we could also look at all routines and habits that we have and that we do without thinking. Then there's a thought-through system which is based on relevant factors, which requires an effort which is based on reasoning rationale and which is more reflexive. Now, the main question for me in relation to this session was what brings behavioral sciences and experiments together? Well, it's when you want to have to combine public policy and experimentation. Why would you experiment? To prove the effectiveness of a concept, to demonstrate causality. Here's a picture of Bradford Hill, who created causality criteria. So the ultimate objective is to make the best use of public money. Why do you want to change behaviors? Without behavioral shifts, there are no effects. And if you want to cause behavioral shifts, of course, you need to understand human beings and not regard them as a rational person. We need to understand the workings of human people. So it's very important to have a scientific approach of public policies and of prevention, not something ideological. And despite the long existence of these concepts, there's still resistance to this dual approach. People often say, why should I experiment? Because I know what's the right choice. If you experiment, that means you have to check your assumptions, and it goes against dominant sets of beliefs. Why should I experiment? Because I know for a fact that this is how I should act. So you have gradually moved from the feeling-based, ideology-based to the evidence-based approach. But there are still resistance to these approaches today. And in conclusion, I'd like to quote something that was an invitation to a recent panel discussion. The idea of the evidence base probably was never so successful as in the last years, particularly in decision-making circles for public health. However, it is often boiled down to a narrow vision of what has been proved as effective on the basis of a positivistic paradigm, which borders on scientism. So that's what people say about what we do.
Merci, Pierre.
Thank you, Pierre.
The next session, which is going to focus on some practical scenarios of using behavioural science to overcome obstacles and resistance and influence individual behaviours. So I'd like to start by welcoming my colleague, Edward Murphy, up on to the stage here for his presentation. And just to say, we're going to have 3 presentations to start with, and we'll take questions at the end of that. Okay, thank you. Thanks, Ed.
Thanks, Caitriona. Afternoon, everybody. Welcome back after your lunch, and it's a pleasure to be joining you all from Ireland. And thank you to Jenny and the Santé Publique France team for having us over from Ireland today. So as Caitriona said, I'm Ed Murphy, and I work as a project manager on the tobacco control programme within the Irish Health Services. So we're going to take a look today at a pregnancy, maternity-specific stop smoking project that we have rolled out in healthcare in Ireland, and then look at how a model of behavioural change might underpin that, and probably how it underpins stop smoking services in Ireland in general, and no conflict of interest to declare. Just to give some context around policy and strategy, and I won't dwell on this, but just so that we can recognise that it's there, Ireland is indeed a member of the FCTC, the WHO Treaty. We have a cross-governmental strategy called Tobacco Free Ireland that was launched in 2013, and that's our government's roadmap essentially to how we get to having a smoking prevalence of less than 5% of the total population in Ireland. So an ambitious target, and you'll see where we currently are with our prevalence in a moment. Healthy Ireland then is a strategy for the health services essentially, and that takes the actions within Tobacco Free Ireland and integrates them into the Irish Health Service. And then on the tobacco programme within the health service itself, we would have our own implementation plans that we generate every 4 years with actions for ourselves. And in 2022, we published stop smoking clinical guidelines for stop smoking services in Ireland as well, and we'll have a look at those in a moment as well. So where are we in Ireland with smoking currently? So you'll see there the trends from 2015 to last year to 2023. These are collected by an annual survey called the Healthy Ireland Survey, and it's a representative sample of around 7,500 people every year. So 2015, 23%, and that has come down to 18%. There was a slight uptick during the COVID year, so you'll see there from 2019 to 2021, 17 to 18%, and 8% of the population currently using e-cigarettes. So we have been successful in bringing the prevalence down in Ireland, but we've kind of hit a wall. It's stopped in the last number of years, and we're starting to look at new and novel ways and kind of start to look at tobacco endgame measures to try to get some really meaningful prevalence reduction between here and the next 10 years. What does the impact of tobacco use look like in Ireland? So look, I mean, huge cost to the health service, 460 million every year, probably a 1.2 billion cost to Irish society in general, 300,000 bed days used, inpatient bed days. That's the equivalent of an 800-bed hospital doing nothing but working on tobacco-related disease all year, every year. So very significant. 4,500 deaths a year. That's 100 people a week in Ireland, thereabouts, out of a population of about 5 million. So, you know, smoking remains the greatest preventable killer in Ireland. 44,000 hospital admissions. But the one positive little bubble on the slide there, and there is one, thankfully, 49% of people who smoked in Ireland had tried to quit in the last year. So most of our smokers, you know, have tried to quit or want to quit. So we do have a target audience, we do have a captive audience in terms of trying to get messages across to channel people to our stop smoking services. Just about our own programme, this is what we want to do. There's the government target of 5% by 2025. Denormalise smoking for the next generation. So we work on the premise that children should not see smoking as a normal health behaviour. In fact, they should not see smoking at all in society. That would be our stance in Ireland. We need to acknowledge tobacco use as a disease and treat it as such, and provide cessation support. So that's things like behavioural support that we look at in a minute, and medications to help people to stop smoking, and then provide tobacco-free environments as well, be that within healthcare settings or in community settings, parks, playgrounds, beaches, and anywhere where there's likely to be children and young people. I mentioned clinical guidelines, so Ireland was a little bit late to the party in terms of a clinical guideline for health professionals to use to direct them in how to provide stop smoking care. I think France has had one since maybe 2015. We definitely looked at the French guideline when we were assessing what was there internationally in order to form our own guideline. So we churned the evidence base, we researched what international guidelines already existed, and then we made some judgments and decisions in terms of what we would include and what we wouldn't include. There was some international quality assurance done. Then those of you that might work extensively in tobacco control would be familiar with Charlotte Pissinger and Kenneth Ward. So they independently reviewed our clinical guidelines, and we published them in January 2022. The next slide will show you exactly what the guidelines recommend, but they kind of took a three-pronged approach. So there are recommendations for our general population, there are recommendations for people who use mental health services, and then there are recommendations specifically for pregnant women. Because I think there are, we were missing targeted services for these populations, I suppose really is what I'm trying to say. And in order to bring the prevalence down, we need to bring ourselves to a space where we are starting to develop more specific targeted interventions for particular types of population groups, and I think that's where we're moving to. So the guidelines recommend that we provide behavioural support. So we do this by asking and recording somebody's smoking status whenever they're in touch with a health service, advising them on the best way and the most supportive way that they can stop, and then arranging that clinical care for them. So behavioural support will look like individual or group counselling. We have telephone support. We have a national quick line, text messaging support, internet, online chat, and all the kind of stuff that goes along with that. And then we made recommendations around medications as well. So varenicline plus or minus combination nicotine replacement therapy. So a long-acting NRT and a short-acting NRT. And I know you'll all be in the same boat here as well with us in terms of varenicline, with it not being available at the moment. But at the time we published the guidelines, varenicline was the most effective method according to the literature in terms of medication. So the clinical guidelines, as I said, direct our clinicians to refer people to intensive stop smoking services. And what do they look like in Ireland? So this is what they offer. They're delivered by specifically trained stop smoking advisors. Some of these people will have clinical backgrounds. They'll be nurses or midwives, physiotherapists, occupational therapists. And then in the community setting, they are generally health promotion staff, health promotion officers. So they're trained to a high level, and we adapt the NCSCT training from the UK to train all of our advisors. And they offer one-to-one behavioural support with their clients. So they'll meet them either in a clinic setting or via phone support. It's a non-judgmental service, so we do aim to create a safe space for people to come and see us. And the support will start 1 to 4 weeks before someone's quit date, and will last for up to a year. And then our advisors will make recommendations about the types of nicotine replacement therapies that somebody might consider using, having looked at their smoking behaviours and their level of addiction with them. And in Ireland, in the last 12 months, we've managed to make all of our nicotine replacement therapy products completely free to anybody who engages with the service. So they're entitled to a free 12-week supply of combination nicotine replacement therapy, so they can get a patch and gum or an inhaler or mouth spray or whatever they choose to use. So this is probably what a lot of you had in mind in terms of the type of behavioural change methodology or model that underpins stop smoking services. I think this is probably what's in use internationally. So it's trans-theoretical model of change, and I suppose what we are attempting to do with people is hopefully move them from pre-contemplation or contemplation into preparation, action, and maintenance. That's what the services aim to do. We know that from our national surveys that most people who are using tobacco are already in pre-contemplation or contemplation anyway. Whether they really realise it or not, most of them are, about 75%. So everything we do is geared towards moving someone from contemplation through preparation and into action, and hopefully then into long-term maintenance. And we know from our service data that people who engage with our services and use medication are for 28 days, and if they stop for 28 days, they're 5 times more likely to be quit long-term than those who try to do it cold turkey or on their own without using services. How does the model apply to quitting smoking? Well, look, cognitive processes first and foremost, so consciousness raising, so a midwife or a nurse will ask someone about their smoking status. Very important to raise that question in the clinical setting and record it. I'm going to speak about a pregnancy-specific project in a moment. So there will be situational reevaluation. Becoming pregnant is one of the most important times of change in a woman's life. And we would argue then it's a really, really good time, while difficult, acknowledging that, a really, really good time to make meaningful health behaviour change as well. People will have self-re-evaluation, they're not happy with their current smoking status, and social liberation as well. In modern society, particularly in countries like Ireland, there is a certain stigma around smoking. You don't see it in public all that much anymore. So wanting to be free of that and wanting to be able to shed and to break free from those change. And then behavioural processes as well. So self-liberation, our services would work with people to really, really help them to believe that they can quit, particularly people who might have tried to quit before and failed, to let them know that with our help and with medication, we can get people over the line. Supportive relationships, be that with the clinician, with the Stop Smoking advisor, or even at home with their families, friends and peers. Counter conditioning, so giving people other options outside of smoking and coping mechanisms. Reinforcement, again, that'll happen all the way through the services, and stimulus controls. So creating a supportive environment for yourself, and things like, removing the smoking paraphernalia from the car, not going to the smoking area if you're out, and that kind of stuff. So like, in a nutshell, that's essentially how the theory will apply to quitting smoking. There are obviously limitations as well. So the theory doesn't take into account social context in which change occurs, such as, people's cultural issues, their home situations, income. The lines of between the stages can be arbitrary with no set criteria of how to determine a person's state of change. And then for our advisors, there's no real guidance for them in terms of how long somebody might stay within pre-contemplation or action, or how long you need to prepare someone. It will very much vary from person to person. And the model assumes then that people make coherent and logical plans. And of course, humans aren't always logical. They surprise you at times. And then it can't account for the fact that people often decide to change their behavior in the absence of any planning. Some people may be in pre-contemplation and contemplation for months without even realizing it. Preparation and action can happen in your sleep, and all of a sudden you're in maintenance when you wake up. So it doesn't account for that sort of spontaneous quit. So maternity services, Smoke Free Start is a midwifery-led stop smoking project that we've run in 2 of our largest maternity teaching hospitals, so in Cork and in Dublin. And the project aims were essentially to train all of our midwifery staff in those hospitals in something called Making Every Contact Count. This is a brief intervention program that we have in Ireland, and this is about trying to move our pregnant women who present to our services as smokers into contemplation and pre-contemplation, and then through the cycle of change. One of the most important introductions here was breath carbon monoxide testing. So every woman, when they attend our maternity services in these hospitals, has a breath carbon monoxide test at antenatal check-in. The same way that you'd have a blood test, a urine test, or a blood pressure check, the breath carbon monoxide testing happens. And if someone has a breath carbon monoxide level of 4 or higher, then they're automatically referred to the stop smoking midwife within the service. People can decline, but the referral happens automatically. And then the BCO test is used to reinforce behavioural change throughout the quit attempt, so people can see that it was high, and when they stop, that it comes down. So it's used to keep people on track. In terms of the type of clients that are using the service, the majority of women 25 to 34, ethnicity, white Irish, about 80%. We had a census last year, and I think the total population of Ireland, 77% of people are identifying as white Irish. So that kind of fits in with our census data, as does the other ethnic data on the chart. It's very much in line with what that looks like in Ireland. Occupation status, most people are working, but then from education we'll see secondary, almost 60% of people left school after secondary school. So it does imply a working class dynamic probably to the type of clients that we have using the service. Previous quit attempts, and this is interesting, most women had not tried to quit before. And anecdotal data from our midwives would say that because they didn't believe that they could. And it's interesting there as well on this slide that 60% of the women would be multiparous. They've had children before, so they may have smoked in previous pregnancies. 57% would have smoked for 10 years or more. A lot of women disclose other health conditions. 27% disclose a mental health condition, and that kind of introduces a more complex social and cultural dynamic to the service as well. In terms of what the outcome measures look like, over 4,000 women will have been referred to these services in these 2 hospitals since mid-2020, August 2020, and 2,257 have accepted and had at least 1 episode of care with the midwife. 832% setting quit dates, and then this is our metric that we use for our service plan, 511 quit at 4 weeks, with 77 women quit at a year. Now, we have had over 1,000 babies born smoke-free, that is, mom was quit on delivery. And that probably implies to us that we have a problem with keeping people in maintenance. Once the pregnancy is over, we do see a lot of women going back to smoking. And obviously, we want to create smoke-free homes for the children to grow up in as well. So that's something that we need to actively look at in Ireland as well. And areas for improvement. So conversion rates from contemplation to action. That's something that we have an issue with. You can see the episodes of care 2257, but only 37% of those women actually going on to set a quit date. So what do we need to do there to help to keep these women moving through the service? We heard a lot about financial incentives yesterday in this room, and we are looking at implementing financial incentives for stop smoking services in Ireland, but we're not specifically looking at pregnancy yet. We're actually looking at areas of social disadvantage to start with. They do good work on financial incentives and pregnancy in the UK, and it does seem to work. So that's probably something where we need to cast our gaze in the future as well. Addressing complex needs, and our midwives will frequently tell us that the type of woman that smokes in pregnancy has other things going on as well. There can be alcohol use, there can be drug use, there can be violence in the home. I mean, it's one of these things, women who are pregnant know that it's not good to smoke, yet they continue to do so. So the addiction levels are very, very high, and there are reasons for that, and generally other things going on as well. So we need to be able to look at how do we address all of someone's needs together as a package. And that kind of contributes to the how then do we keep people in maintenance. So the women that do manage to successfully quit and hopefully be quit on delivery, how do we then keep them smoke-free? Is it through provision of stop smoking medications? Some of our medical staff at home, particularly our GPs, are sometimes slow to recommend that someone who's pregnant would use nicotine replacement therapy. And we're trying to change their minds around that as well, because from our perspective, it's preferable to a woman keeping to smoke. So good work done, more to do. Happy to take any questions after the session, but I hope that was useful to some of you. Thanks a million.
Thank you, Ed. Good news story there from Ireland. So I'd like to just welcome to the stage now, and apologies, Sandrine, for pronunciation of your name, but Sandrine Randriaman-Pianina and Alice Escand, who are going to talk about using behavioural science to overcome obstacles and resistance and influence individual behaviours in the proper use of antibiotics. So thank you.
Bonjour à tous, donc je suis effectivement Sandrine.
Hello everyone, my name is Sandrine Randriaman-Pianina, and with Alice we're going to talk about the contribution of behavioral sciences to the design of a system for the correct use of antibiotics. And I will let her introduce herself. Hello, my name is Alice Escand. I work at the Behaviours Insights team, so that's a public authority, and we were lucky to assist Santé Publique France to work on that subject.
Ah, la grosse flèche. Et donc, petite slide très rapide pour dire que je n'ai pas de conflit d'intérêt.
Just a quick slide to say that there's no conflict of interest for myself and my colleague. We've been working for quite some time now on monitoring antibiotic consumption and the development of resistant bacteria. But we took over the communication and prevention role in 2019. So initially, the aim was to develop an awareness campaign on antibiotic resistance to reduce antibiotic consumption, because France was a huge consumer of antibiotics, and to slow down the development of resistant bacteria. So we'll start with the end. And this is where we ended up. You have different posters that are part and parcel of our marketing, social marketing campaign. And we will show you the video that has been broadcast since 2022. I'm sure you've seen it.
Enfin, le week-end arrive et pas de bol, c'est la grosse bronchite. Ma pauvre Zoé.
Well, the weekend, we are on during the weekend, and you have the flu. That's not... What a problem, but you want to take antibiotics, but that doesn't have an effect on viruses. Oh, wow. If you want to cure yourself, you have to use antibiotics as you should. Come on, Zoe, it's just a pullover. Doesn't matter.
Alors, ça ne vous aura sans doute pas échappé, hein, j'ai dit que la demande...
So I said that at first the request was to develop a campaign against, to raise awareness on antibiotic resistance. There's nothing about ATBR, and there's no message as to induce people to fight antibiotic consumption, but we have basic messages on the efficiency of antibiotics. We recall that they only work against bacterial diseases. We mention the pathologies that are concerned. We recall that they have no symptomatic scope, that they do not cure faster. They need a medical opinion only, and only a health professional's prescription would prevail. So how did we end up having an educational campaign on the correct use of antibiotics? Well, what we did, what we usually do when we receive requests on social marketing, we looked into the literature, we looked what was, tried to see what existed already, so as to find an inspiration and to fine-tune our strategy. However, what we realized that the only campaign that existed on the consumption of antibiotics is the French one that we all know, with the slogan, "Antibiotics are not automatic." And we realized that quickly we needed to adopt a test-and-learn approach. We needed to devise our own strategy, and we knew that our path would be littered with a lot of hurdles. So we made a survey to try to see from a pragmatic way how the consumers react. These surveys had already been set up by the sickness insurance fund. And despite 10 years of lack of communication on the subject, knowledge on antibiotics remained good, even though they were incomplete. What we saw was that there was a good level of information on the use of antibiotics, so people knew that antibiotics were efficient only on bacteria. There was an increase of 10 points since the last survey that was carried out in 2010, but only 50% of respondents thought that it was useful. There was a persistence of false beliefs and lack of knowledge about the infections against which antibiotics are effective. So that shows that the campaign helped to know that the use of antibiotics is not automatically good when we want to fight the flu, for instance. As for the level of knowledge about antibiotic resistance, 60% of those questions, compared with 56% in 2010, said that they had already heard of antibiotic resistance. And among these responses, 60% of spontaneous quotations mentioned mutation and the resistance of bacteria to antibiotics. So we were quite confident. Nobody has talked about it for 10 years, yet. Oh, okay, it's not optimal, but the level of knowledge on antibiotics and the way they operate and ATR works quite well. So what we decided was to develop messages that are two-pronged. First, to reinforce knowledge, consolidating the knowledge that I mentioned earlier, and knowledge on ATBR, and to mobilize people on the subject. When I talk about population, I mean the general public, but also health professionals, because we're talking about medicine that is prescribed. And then the other important objective is to encourage people to make a better use of antibiotics, and mainly to change their behavior by reducing their consumption. So we developed 3 creative ideas, all focusing on the consequences of the misuse or good use of antibiotics and the need for everyone to adopt appropriate behavior to prevent the development of resistant bacteria. These are the tracks for thought, but there were also quality interviews with the general public and health professionals, and in a nutshell, none of the tracks worked. So, what we realized is that there were too many messages, there were And when we made quantitative declarative studies, we didn't find it in the quality studies. We didn't have any echo on that. It was very low on the use of antibiotics and on the ATBR. So when we had multiple choice questions, they would actually answer randomly. The vast majority of the population didn't understand that it was not the body that is resistant to the antibiotics action, but rather to the bacteria itself. So we had to start from scratch again, and we needed to find a new angle, a new way, a new means to a good driver for the population to understand. This is why we asked my colleague to help us. Thank you, Sandrine. So, when we started with our assignment, before starting with our assignment, we worked on the behavioral model to explain the correct use. So we focused on patients, and we wanted to work on reasonable consumption, namely only for bacterial infections without any self-medication. And we would urge people to respect and comply with treatment duration. Once we have set the objective, we have worked on a behavioral model, a model that would define stages or key prerequisites that would lead to the behavioral change that we want to bring about. First of all, we relied upon existing models like the BIP. I don't know if you know it, capacity, opportunity, motivation. We simplified it, we reshuffled it, and this is why we have created this model, knowledge, well, to know, to want, to have power and to act, to be able to do something and to act. So we needed to, first of all, to know what is an appropriate, a suitable consumption, the consequences that it can have, and the person needs to want to change. The person needs to be able to change, to have the capacity to change, and also the opportunity to act. When we talk about opportunities, we mean social and physical opportunity. Once we have established this model, we wanted to find the main hurdles. There's already existing literature on the hurdles to that type of behavioral change. We relied upon documentary research, and we relied upon the opinion of experts. So we found multidimensional and diversified hurdles. These are the four main hurdles. When we want someone to know, to want, to be able to, and to act, we want the public to know about the way the antibiotics work, because there's a lot of knowledge gaps. What is a suitable consumption and what is ATBR? Antibiotics are also perceived as a default treatment, as a silver bullet for any kind of infection. As for antibiotic resistance, it is not taken seriously because it's not taken seriously, and we don't see that it's capable of fighting infections in the future. And also to act. Some people would think that that's the role of doctors, GPs, and even though there was antibiotic resistance, they would say, okay, someone would find a solution. And then a lot of awareness-raising campaigns on ATBRs showed that there was not a clear call for action. So that means that the population didn't know what to do. When we want to raise awareness of a threat without giving a key to action, then it can be counterproductive. Once we have identified these hurdles, we decided to co-build, co-design our campaign with our public authorities partners, and to have some paths for communication based upon what we identified with different levers coming from behavioral literature. So there are 4 different tracks, and we wanted to test them out, to test their impact, their efficiency. So, in a nutshell, we did an online experimentation with 4,000 people, a panel of 4,000 people living in France, and we have divided them in a random way into, we've broken them into 4 groups, and we've handed out some questionnaires. So these are the 4 tracks. The first one is to highlight the harmful effects of antibiotics on the body, on the immunity system. So we try to reduce it to the immediate personal effect. Then secondly, we focused on education. We used common language where antibiotics can be useful or not be useful. And we've referred to concrete and tangible illnesses. Thirdly, we talked about the consequences of ATBR in the present for people affected by serious diseases because of ATBR. And then, last track, we should talk about the precious nature of antibiotics, that it should be seldomly used. And this is also the message conveyed by the Ministry of Health. And we tried to have a punchy and short version message to make sure that the message comes across. So we wanted to know what the impact was on how to memorize, to remember this key message. Would that induce to an awareness raising among the population that would help the population to take ownership of this message and then to act? That's an online test, so we are a bit restricted on the monitoring, but these are good indicators. So there's a lot of results. Okay, I'm being told that I'm lagging behind on my schedule, so I'm going to speed up. So first of all, the first outcome is that the message that is directly communicated on antibiotics as being useful or not useful was the message that enabled to increase knowledge on the subject, but also the intention to act. The second key message is on messages which mention ATBR, we saw that it would actually deteriorate existing knowledge. Some people wrongfully thought that it's the body getting used, and so we would need more antibiotics. We saw in our survey that it was the case for half of the respondents, but in the messages where we would talk about ATBR, this proportion would increase significantly because there's an association that would be done between ATBR and the body. And then something else that is quite interesting, but that would not be supervising, the short version of messages would be more efficient and people would remember them more easily. So as a wrap-up, even though it is tempting to talk about ATBR and to raise awareness on this threat, we saw that there was a real need to raise awareness among the general public about the use of antibiotics and to explain concretely what works, what doesn't work. And to wrap up, because this is how we ended up with this campaign that we showed earlier for the general public, where do we stand today? Because with the dissemination of this campaign that started in 2022, we made other tests. We started in January with results that are quite positive. 1 in 2 French people recognized the campaign. They understood the message well, and they understood that some antibiotics are good for some illnesses and some are not, and they understand which ones. It is also a good incentive because the issue was to entail behavioral change, and 1 in 10 would actually ask themselves whether antibiotics are useful depending upon the illness they have, and 1 in 10 would be induced not to take antibiotics if they don't have a doctor's advice. So we also renewed the KBP service to measure changes in this, to see if these indicators were consistent with the survey that we carried out in 2019, to see if there was an evolution amongst the general public and the health professionals, and we hope that the outcome will be positive. We will develop a new campaign and we will add a new message. We will continue to consolidate the knowledge, but we'll focus on the risk of loss of antibiotic efficiency in the event of antibiotic misuse. So we actually increment the content of the messages so that we'll focus on the fight against TBR in general. Thank you. Thank you, Sandrine.
So I would just like to now introduce the last two speakers for this half of the session. So Anne-Juliette Seri and Professor Damien Tessier, and they're going to be speaking about encouraging teenagers to take part in sport. Thank you.
Bonjour à tous. Donc nous allons faire une présentation.
Good afternoon. So we'll be presenting today two different systems, but the objective is the same. How can you encourage teenagers to be more active? So we are really in line with the theme of this conference, physical activity, which has been elevated as a national cause. My name is Angela Tsiri. I'm going to be presenting a social marketing system to increase physical activity and reduce or fight sedentary behavior amongst 11 to 14-year-olds. Now, something which is quite common, quite similar to Damien's presentation. Of course, we know that physical activity has a lot of advantages amongst young people, not only young people, of course. So there are physical and mental health benefits, psychosocial ones, and of course also on academic performance. But these benefits are not so well known as the others. Now, why do we want physical activity levels to be maintained in teenage years? We know that those who do sports or take physical activity as teenagers are likelier to continue as adults. Unfortunately, surveys suggest that public policies are not very good in terms of teenage physical activity, but it's common to all developed countries. Amongst 6 to 17-year-olds, 51% of boys only do take exercise and only 33%. Or at least, well, only 51 and 33% meet recommendations. And there's a major drop in high school amongst 11 to 14-year-olds. Only 33% of teenagers and of male teenagers and 20% of female teenagers are in line with recommendations. And screen time increased of approximately 1 hour per day between 2005 and 15. And I suppose we can imagine that this screen time has even further increased since then. Now, we know that interventions can be effective, particularly when there's something for a role for families to play, also when the school environment is involved. And we have an example of a campaign carried out in America, the Verb social marketing campaign that lasted 3 years. It had a lot of effects. It really revolutionized behaviors, particularly amongst young people. So the question is, how can you increase physical activity amongst teenagers to help them meet recommendations? Now, we worked on this theoretical model with the BIT, with Alice, who just gave a presentation. To design this theoretical model, we first did a literature review. We then conducted a quantitative survey with 70 parents and about 30 teenagers. And this helped us build this model. Of course, it starts from the theory of planned behavior. I'm not going to go into detail into this, as Damien will be telling you more about it. But in a nutshell, if you want an action to take place, there has to be an intention. So you need to work on the drivers of the intention, the knowledge, the beliefs in behavior, also the perception of social norms, and also one's self-perception to be able to take physical activity. But we know that a lot can happen between the intention and the action, especially social and structural environmental determinants. For example, the family organization or structural determinants, as discussed yesterday in the OECD's presentation on physical activity. So, for example, the accessibility of cycle lanes, opening times of gyms or sports facilities. Are there any safe parks in the vicinity. These are unfortunately levers that we have no control of at Santé Publique France. So when we do social marketing systems, we try to act on behavioral levers. And amongst these levers that we identified were a number in relation to the emotions related to physical activity, but also the family's social influence. And we decided to specifically focus on this. Now, let's look at a few teachings from our literature review and the quantitative survey. We can see that physical activity is still very much connected to the concept of sports. Also, the attitude to physical activity is positive amongst parents, teenagers, active and inactive individuals, and benefits are well known, so we didn't need to work on that. However, recommendations in terms of physical activity are poorly known, and we found that parents overestimated the physical activity of their children based on non-objective criteria. For example, for parents, sports classes in school was enough. So we saw that we had to work on this specific lever. Now, physical activity really suffers from a drop when children enter high school due to the change in times, commuting, many different factors, and also you don't behave in the same way. You don't play anymore in the schoolyard. The main motivations for physical activity are the recreational side of things, the fact that it's social, you can do this with your friends. But there are some clubs and competitive practices that act as a turn-off. And also, as we heard from the OECD presentation, it is as important to take action in the sports communities, amongst sports clubs. They have to become aware of this to offer something that is attractive to young people. Now, the main obstacles amongst teenagers is mainly in relation to motivation, so the can't be bothered attitude, something that was quite recurrent in the explanations, and then more structural obstacles in relation to the offer of in physical activities, transport, access to infrastructures, and the cost of sports. And this is particularly an issue for low-income categories. And also it affects more female teenagers than boys. Now, we worked first on parental support, and the earlier parents provide support in teenagers, the better. Now, what matters most? Encouragements from parents and driving your kids to sports venues. However, if parents force their teenagers to take physical activity, if there's an excessive control, it can have an adverse effect on physical activity. In France, we can see that parents are aware of how important it is to support their children, but again, there are a number of barriers, of obstacles, and what we saw in the literature is that parents encourage their children. They encourage their children when they are confident that they can do that, and that when they are confident that encouraging their children will have an impact on physical activity. So we decided to work on this. So we started a system targeting two populations. There's one system targeting parents, which is what I'll be focusing on today. We want to encourage the involvement of parents and give them tools to encourage the physical activity of their children. And then another system targeting youngsters. We did not try to work on the intention. We tried to work on the here and now and how you can encourage young people to take physical activity. But I'm not going to be presenting this today. Now, in short, what did we try to achieve with this social marketing system? We tried to encourage parental support, to motivate parents to be more active with TV commercials or advertising on the web and in cinemas. Also explain what physical activity is, present the different forms of parental support. For example, helping your child to find a specific activity, take your children to the sports practices, do sports with them. Also, we needed to publicize recommendations and encourage parents to assess the level of activity, of physical activity of their teenagers. We had a tool online on the Manger Bouger site. And fourth, offer practical and accessible solutions to parents to help them support their teenagers. So I'm not as courageous as Santé. I will not try to play this video, but I'm sure you already saw this on television. The theme of this campaign is it's not easy to have your teenager take physical activity, but encouraging them is important. So we tested this out with both tests. So how was the campaign recognized and perceived? We also did an impact analysis. So we followed a cohort of 4,000 parents. We questioned them on a number of criteria before the start of the campaign and just after it, and 10 months further down the line after the campaign. So what were the criteria that we tried to assess? Well, their attitudes as to the benefits of physical activity, their attitudes in relation to support, also the perceived behavioral control, what could be the potential impact. So we know that we have different forms of parental support. I already mentioned this. And finally, does it have any impact on the different forms of physical activity? Now, I'm not going to present the results in detail, but what you can see is that when we focused on all parents, there was little effect. There was only an effect on one form of parental support, that is taking physical activity with your teenager. However, when we assessed this with parents that started from a low level, the impact was much bigger on attitudes, on the perceived behavioral control, and on parental support. But it did have an impact on the self-reported activity. Unfortunately, we could not fit children with accelerometers, but it did have an impact. So in conclusion, we have encouraging results, particularly for people who had a very low starting point in terms of attitude, of perceived control, or as regards the level of physical activity of children, and results were even better amongst low-income categories. And sometimes these results even were maintained after 10 months. So thanks to this success, we decided to start the campaign again in 2023 with changes following the post-test findings. And as I was saying, we had enough parents in the cohort to establish a third assessment milestone. Unfortunately, we haven't analyzed these results so far, so I can't share them with you, but we are really looking forward to assessing these results after the new campaign. And over to my colleague now. Thank you very much, Anne Juliette. Thank you for your presentation. So I'm also going to be talking about health psychology and the theory of planned behavior. My name is Damien Tesset. I work in the sports and social environment laboratory at the Grenoble University. It's the SENS laboratory. We talk on persuasive communication and planning intention. So we try to increase the intention to take physical activity, and we work on the planning of intention, which is more focused on behaviors. So we want to increase the effects of intention on behavior. I do not have any conflict of interests. Now, I'd like to first come back to Prochaska and Di Clemente's trans-theoretical model. I'd like to share a few key ideas. First, we've known for the last 40 years, more or less, in health psychology that behavioral changes do not occur automatically, and it's not something stable. On the contrary, it's progressive, and there are many relapses. And it's not that easy to change your behavior durably. There are several stages: decision, action, and maintenance. And today, works highlight a number of levers that have to be actuated depending on the stages of the target populations. So if you're looking at people who do not have yet the intention to change behaviors, you would rather be looking at socio-cognitive approaches, such as the theory of planned behavior, the TPBs, with persuasive messages. However, when people already have had the intention to change, but if it's difficult to move on to action, you'd rather be looking at behavioral approaches with self-regulation strategies. And there are lots of theories in the literature. and I'll be looking at behavioral planning strategies. One of the most iconic theories in health psychology is the theory of planned behavior by Eisen, TPB. So, as Juliette has said, this theory regards people as rationally processing information. So, according to this theory, you just need to give information for people and they're going to change their behavior. So, this is based on three variables: the attitude, the subjective or social norms, for example, being influenced by your family, your friends, and the perceived behavioral control. That is, you are confident in your own ability. I have decided to act upon my resolution, so I can do it. Now, when you look at meta-analyses on this, there are two types: correlational meta-analyses that highlight strong relations between intention and physical activity behaviors. So it's 0.5. So once people have decided to change their behaviors, there are clear and observable effects in self-reported studies with questionnaires. However, in more experimental meta-analyses that tested intervention, the effect is much more moderate, particularly in the relation between intention and behavior. The effect is not 0.5, it's 0.07. So, as evidenced by some works by, for example, Rhodes and De Bruyn, there are people who have the intention, but they do not take action. It's what you would call willing abstinence. So it's essential to see how you can reduce this gap between intention and action. And that's where behavioral change techniques can play a part. There are many of them. We've looked at a number of studies, and we've particularly focused on planning strategies, planning action. You decide when, where, with whom you're going to take physical activity, and also planning, taking into account obstacles, barriers that may prevent you from doing this physical activity, and identifying solutions to try and overcome these obstacles. Now, more specifically, in the first study, we focused on teenagers, inactive ones, so teenagers who, according to definitions, to the recommendations, take less than 7 hours of physical activity in a week. So we went to sports classes in schools, and we started to identify inactive or insufficiently active children. So we took one endpoint, 30 minutes, less than 30 minutes a day. And we tried to test out 4 conditions. First, the health message. You might think conveying a persuasive message on health, saying that sports or physical activity is good for health, is a good thing. Well, actually, it doesn't work. It doesn't work. Teenagers do not feel really concerned by messages that really stress on the importance to take physical activity for health reasons. Then we looked at so-called salient beliefs, the fact that physical activity can be enjoyable. So it was the more experimental condition. Third condition, they would not receive any persuasive message. They wouldn't be told why they should take physical activity, but we encouraged them to plan a number of slots for physical activity in the week. And for the last condition, we had a combined group with one message on enjoyment and one message on planning physical activity. So we had 3 measurements. We had T1, T2, T1, T2, T3, and a post-test in the 3rd stage. So we measured intentions, attitudes, the perceived behavioral control, and using the IPAC, so it's a self-reported measurement of physical activity, we measured their activity. So the results that show that as regards the physical activity variable, none of the 4 conditions had any effect on behavioral change. If you look at intention, we can see that the 2 persuasive conditions, whether the health message or the enjoyment message, none of them had any impact on intention. What are the last two conditions? Planning and the combined condition, well, they did have an effect. They increased the intention to take physical activity. And as regards attitude and perceived behavioral control, we had mixed results. So the interesting takeaway here is that persuasive communication does not seem to be effective with teenagers, as Anne-Juliette said earlier on. They already have the attitude and the intention to take physical activity. So the objective is not so much to increase intentions, but to help kids to take action. The second takeaway is that planning can be a useful strategy to increase intentions, particularly the perceived behavioral control. When you plan what you're going to do the next week or the following week, you increase your confidence, your self-confidence in taking action. We then did another study to enhance or enrich the previous one. First, we wanted to better target our message, and second, we wanted to use a more objective metric of physical activity with an accelerometer. So we benchmarked three conditions. A first message that would highlight that physical activity is good for your well-being. It's a good thing against anxiety. It's good for your overall well-being, for mental health. So it highlights inherent goals. The second message also highlighted the fun, the enjoyment of physical activity, but it was more about in here or outside characteristics. Physical activity is good for my figure. So you have two different categories of enjoyment here. And the third condition was the a control condition where we only gave an information saying that it was important to do physical activity in the teenage years. So same experimental system with a post-test, a pre-test, intervention, post-test. So after the intervention, we gave teenagers an accelerometer that they wore on their waist. Also, in the green and red conditions, we had a persuasive message. So we combined the persuasive message and planning. Now, in the green and red groups, between pre-test and post-test, it has increased intentions, no effect on the perceived control. Now, we wanted to see what were the results with the accelerometer, and we saw that on the main interest variables, so it's the moderate interest. So whether the message of all the planning, it did not really have any effect. However, it did have effect on moderate physical activity. Encouraging teenagers to plan ahead means that they're going to walk to high school, they're going to take the stairs instead of using the lift. So it's not exactly the type of behavior that we target, moderate physical activity, but maybe it can be a stepping stone. So really here, three takeaways. The first one, you can have reservations about the effectiveness of persuasive messages targeting teenagers because we already have the intention to take physical activity. However, planning, this behavioral shift seems quite promising. Moderate activity, as I was saying, seems to be an intermediate stage before teenagers can take more physical activity and reduce their inactivity time. And this intervention was quite limited. We only did one intervention that lasted only 30 minutes. So I think we would need to train physical activity or sports teachers going forward so that they can convey this message and so that they can implement these behavioral change techniques in order to raise the dose of intervention, so to speak, and to have greater effect on physical activity. Thank you very much for your attention.
Thank you, Damien and Juliette. If you wouldn't mind staying up on the stage, if that's okay, and if we can invite our previous presenters to come up, because I'm sure we have plenty of questions from the audience, and if not, I know we have some online. So if you do have a question, we'll let you see. If you do have a question, if you could put your hand up, we have some roving mics in the room and they'll come to you with the microphone. And if you wouldn't mind introducing yourself before presenting your question. So we have a question here at the front. Thank you.
Denis Charpin, ex-Marseille Université à PPA.
Marcel from APPI. I had a question for Marcel on the consumption of antibiotics. I was a bit surprised that the secondary effect of such as the destruction of the microbiome would not be a deterrent effect. So what about younger children? It seems to be. It seems that there's a higher consumption amongst the young children. Yes, this was based on the quotas. To tell you, it's good that you asked the questions. We really believed in it. We thought that we often talk about the microbiota, and it's like a second brain. I don't have the results in mind, but that's one of the paths that proved to be less efficient, the least efficient actually. And also we saw that there was a rebound effect where there was then afterwards people who would want to self-medicate with any kind of medicine available.
Do we have any other questions? We have a lady here at the front.
Oui, merci beaucoup pour tous ces interventions.
Thank you for all these inputs. Valérie Lafontaine. I'm specialized in public health, and for a long time I took care of teenagers and did work on physical activity. I would like to ask the second speaker the following question. 30% of that population practices sport, is a practitioner. What do we know about the characteristics of that population? That's one question that appeals to me. Second question, we know that family is important. It can be both a driver, but also a hurdle. And fathers have an important impact. Why don't we use that population of sport practicing fathers? I don't know why we haven't talked about it yet. Answer. Thank you for this question. In literature, we find several references to that. As Juliette said earlier, the younger we practice sport, the longer we practice and the more foreseeable they are and the more enshrined in our daily practice they are. And so parents have a role to play to make sure that the children would practice sports. It has also a socializing effect. We have to break habits as well. This is what we saw during the pandemic, because we need to have a routine. This is what is important. We know that on Mondays we have training. We know that on Sundays we have a match. And when our habits are broken, then we're a bit confused. Often teenagers were used to some kind of routine. Everything surrounds all their daily activities are actually laid out to make room for physical activity. As for fathers, there are different levels: teachers, fathers, parents, individual capacities. And social norms also are important, especially with teenagers. There's a lot of works, a lot of studies have been carried out on social levels, and opinion leaders of pupils can help to induce pupils to sport up. As for determinants, we've seen a lot of health behavioral indicators. Some for those that live in families where they have studied less, well, they would carry out less physical activity. Girls would actually practice less physical activity. But beyond the notion of CSP, would parents practice physical activity? Would they practice sports? It's very important beyond the CSP. And as for parents and fathers being a driver, being a role model to follow. In the literature, there's a publication in 2002 whereby father's inducement is very important for young girls as well. That's also, that gives us food for thought as well.
I think we have a question here at the front.
If I may, Caitriona, we have many questions on the chat, so maybe I'll take just one or two and then come back to the audience, if you're okay. Et pardon par avance, parce que je pense qu'on ne pourra pas répondre à toutes les questions.
And sorry, because we'll certainly won't be able to answer all questions. I have a question on vulnerable population groups. How could we draw upon social marketing mechanisms to target such population? Socioeconomically vulnerable population groups, there's certainly a lot to do. What do you think about this? Would anyone want to take the floor? Yeah. The social benchmark is important for vulnerable population. We have to be careful when we see the, for instance, if we look at the socio-professional category that is underprivileged, there would be a different response to antibiotics. They are more targeted in our campaigns when we carry out our works, our prep work. We're very vigilant as to assess their level of knowledge to make sure that they integrate their perception of our message. We know that false beliefs were more integrated amongst the underprivileged population groups. As for those that are even more vulnerable, I'm not talking about underprivileged population groups, but with those that have problems with housing, then it would be even more important to have ad hoc systems. With Santé Publique France, we worked with MOBCO on the construction of messages with stakeholders. These initiatives are different, but they complete each other. What we try to do for the general public is to integrate as much as possible. We try to integrate these population groups. We work in the same way. When we say that we factor them in, we do it when we design our campaign messages. We make sure that they're well perceived, well understood by everyone, especially by those that are underprivileged. We try to make sure that they have the right exposure, that they get acquainted with the message, and then we want to make sure that they have understood the message. Especially with the young people, we saw that there was no difference in perception of the message, irrespective of their social class. The impact was more on how physical activity was practiced. Maybe another question from the chat before going back to the room. Edward, let's go to Ireland now. To quit smoking in Ireland, do you do also primary prevention to make sure that the young people do not smoke from the get-go, and which that would explain why you have such outcomes in Ireland?
Yeah, so we've been doing primary prevention for young people in Ireland for quite a few years now, and it has been very successful. So we would have had a prevalence of tobacco use among school-age children. So let's take maybe, your 10 to 17 age bracket, something like that. Might have been as high as 25 or 26%. And in 2023, that is down to, and correct me if I'm wrong, Caitriona, 7 or 8%. It's about that low. So we have done very, very well in taking the youth prevalence down. I'm going to open a Pandora's box here now and say e-cigarettes and vaping. I was a little bit concerned recently when we've seen data from Europe, from the SPAD study, from the European School Survey on Alcohol and Other Drugs, the Irish arm of the study, and I think most of the other country arms as well, were indicating that youth smoking is on the increase a little bit as well for the first time in quite some time. And we had some local research at home. We had our health research board do an evidence review of e-cigarettes and vaping for our clinical guidelines, and they've identified that they think there may be a 3 to 5 a young person who vapes may be 3 to 5 times more likely to take up tobacco use than a young person who doesn't vape. So we're concerned that vaping e-cigarettes might lead to renormalization of tobacco use in Ireland. And I suppose I should mention as well, the indoor workplace smoking ban in Ireland was absolutely pivotal to bringing youth prevalence down, because it started the denormalization process in earnest, that kids did not see smoking in pubs or restaurants or bars anymore, and that was 20 years ago this March. So that, I think, was one of the big ticket items that really helped.
So we might just open it back up to the floor. So at the front here. Yes.
Merci beaucoup, Marc Bardot. Je voudrais...
Thank you. I would like to carry on tobacco. So the ambition is to reach 5% by 2025. It's not very far away, right? So is that an objective that is reachable? So would it be reasonable to say we'll go from 18 to 5 when we see that the figures are reaching a plateau? And if we set an objective that is too ambitious, isn't there a risk to be discouraged, to give up, because we see that we cannot reach that objective, and then we just don't do anything anymore?
So it's probably, it's handy enough that the Department of Health officials that put that 20 or that 5% target by 2025 are now retired. So that's useful for them. So look, absolutely not. Of course, an actual reduction of 13% in prevalence in the next 12 months, no, that's not going to happen. The Department of Health at home are actively reviewing the strategy, and it's likely that they'll put 10 extra years on that target, so they'll push it to 2035, which is probably still very ambitious. If it were 2045, I might say, okay, realistic enough. But there needs to be radical policy shift to get that meaningful prevalence reduction out. I mean, like, the low-hanging fruit is well and truly picked. And to really, really, really start to bring that prevalence down, novel, radical legislation is what's required. It was hopeful looking at New Zealand when they said that they were going to move forward and do their legislation banning age of sale for children born after 2009 or before 2009. But unfortunately, they've rolled back on that due to a change of government. I know the UK has now announced legislation of a similar ilk. They'll likely have a change in government in the next couple of weeks as well, but I'd say a Labour government is more likely to continue to push forward that type of legislation. Interestingly, New Zealand were looking at denicotinisation of cigarettes as well, so they were looking at having a legal threshold on the amount of nicotine that's legally allowed to be in a cigarette, and we are increasing the age of sale to 21 in Ireland as well. They probably don't go far enough. And I had a conversation with Dr. Ruth Malone last year, who was doing an input to an event for us. Ruth is the editor of the journal Tobacco Control. She's based in California. And she's of the opinion that we need to move away from placing restrictions on the population. We shouldn't be trying to tell people what they can and can't do with laws, but that we need to start putting restrictions on industry. That we need to start punishing the tobacco industry more. And maybe we need to make some bold political leaps in that respect as well, not just in Ireland, but across Europe.
We have time for more questions? Maybe one more?
One more on the chat, from the chat, okay. Sorry. Last one. Dernière question. Une question qui peut paraître...
A question that seems maybe An anecdote, but what about the ATBR campaigns? What are the vectors? Because I did not see your campaign, and maybe it would be interesting to know what are the targets for your media campaign, for your communication plan. Yep. This is a campaign that has been broadcast in 2022. It was a low-budget campaign at first, and because of the budget constraints, we had to set priorities for our targets. So it was based on the findings on antibiotic consumption. This is why we decided to target the elderly people, the parents of young children. These are the two target groups, and we decided to have a digital radio campaign and we aimed at targeting these groups because young parents would tend to listen to the radio. Same thing for the age group over 50 years of age, obviously. And we wanted to target them, and we launched a campaign and tried to use the media that they would listen to. We amplified the dissemination when we obtained a bigger budget. We expanded, but we did not have budgets that are similar to the others. And that allowed us to target the general public and to have a better exposure to our messages. But these are mid-size campaigns, and this is why we rebroadcast our past messages. A one-time campaign is not enough for the message to be conveyed, and if we want it to come across and to be listened to and understood, we need to repeat and repeat what we're saying.
Thank you everyone for your questions and for the questions online, and to our wonderful presenters here. Thank you for your presentations today.
Merci encore aux orateurs de cette première
Thank you for the first part of the session. And now we will carry on and we'll ask ourselves how we can use scientific findings and experimentation findings to integrate them and convert them into public policies. That's a very interesting topic, and we will start. We have another surprise for you. We have changed the order of interventions, so we'll have Stéphane Giraud, who's the head of Behavioral Science Department, and he will talk to us about the High Authority for Health to screen domestic violence. Thank you. I actually had to walk to reach the mic, so I did PA. So now we're going to talk about the issue of domestic abuse and the mobilization of health professionals around this issue. This was done at the request of the HAS, the High Authority for Health. The first element of context, I'm in line with my ethical values. There's no conflict of interest. Secondly, maybe you saw me yesterday. This is an interministerial department, so we work with different departments to make sure that it is efficient. And I will make an extreme summary of our pathway, but we digged in behavioral science, and we decided to apply it to different realms of public policy. This is why it's so wonderful what I'm doing. You can see a lot of issues that come to us that we're faced with different agendas. For some topics, we would think that the behavioral aspect is structuring. Same thing for sport, same thing for health. This is the case also for the environment. There's not a lot of issues that would make an exception to our playground. The problem with that is that our scope of intervention and timeline is limited because we are always on a tightrope when we work, and this is why I'm going to explain to you what I'm going to explain to you. Sometimes we have a scope of activity and a tight a schedule when we have to work, and we cannot have a 360-degree overview in our work. This is why we're sometimes frustrated, because we cannot work head-on on a subject and have a partial view. So these are the concerns. This means that the public policies, the way we design public policy mechanisms, need to be integrated in a logic of project. To use a terminology that is quite run-of-the-mill, we need to make sure that public action is enshrined in the reality of our daily lives. This is why we talk about behavioral science. This is why we use these terms. The aim is to be more widespread, to be more encapsulating, to make sure that failing public policies are redressed and rectified, to make sure that they are successful. So we need to establish a diagnosis with a right way of activities. We need to take ownership of the public policy and do it and decipher all these public policies. We'll dig in legal, technical, financial issues, and we'll try to reconcile this with behavioral issues that are related to the public policies. We'll not try to reinvent the wheel, but we'll rely on scientific literature, and we'll complete with some gaps that exist. And we'll try to resort to different methodologies that will not, and I'm going to repeat myself again and again on that subject, that would not be the ideal solution, but whatever we could set up will be done because of our partners and the subjects that we are submitted with. In the end, what we want to have is a state of play. We want to we know the difficulties encountered and why some public policies are facing hurdles. We'll do more, we'll tackle more the psychological aspect, but also technical and material aspects, financial aspects, cultural aspects. So a full horizon. And then we'll try to find solutions. We'll do it and try to be pragmatic, because I'm a pragmatic boy. And what we want to do is to set up efficient solutions, but also we try to be concerned with the administrative constraints, the financial constraints, the timeline constraints, the contact that they might have with the general public. We have to see what is doable. And sometimes it's quite wide enough what we can do. We have to see the way in which we present things. Communication is also part of our work, but that's not the main job in our behavioral science. We try to be wider in our approach, more structuring, with regulatory schemes, financial schemes. We try to make sure that it matches our diagnosis. The reality is that often we have to make a communication exercise that would actually bring ambiguity about behavioral science, because often we're being submitted with a case when the public policy is a failure, because often the general public doesn't understand that it is a beautiful public policy, and often it is all a matter of communication. So sometimes we have to change our angle and have a more structuring approach. We try to prototype our ideas depending upon the guidelines and the approach that we want to have. And we want to avoid some relapses in failures. And what we want also to do is to think out of the box, and something that would be a cultural fight and technical fight. We try to experiment. And we try to do so with randomized trials, but we try also to do it with a lot of pragmatism, because these practices are being faced with some ethical problems, especially when we do trials on population, especially for public policies. That could be a bit complex, but also we could be faced with reality problems, financial and technical constraints, and depending upon the subject. The first work we did on behavioral science that would work on TV registration with one button. I could test something with 2 million people. On other subjects, we won't have this opportunity, and we would do experiments that would be more degraded, that would be less ambitious. So all this is a wheel. Why is it a wheel? Because it's a virtual cycle. And what comes out of the assessment could feed in the diagnosis. And what we want to do is that with all the solution elements, the behavior, everything can change. And so for this, we have to start with a clean slate. And this is why, when we work on public authorities and mechanism, this is a small cultural fight. Pierre Arwidson explained that first, that everything would be in a logic of promotion of absence of public policy, which is evidence-based. Yes, but we are working also on public policies that can be quite hard to implement sometimes. And now I'm going to talk about domestic violence, domestic abuse. So that was a failure. There was a recommendation that for good practice that aimed at increasing the involvement of healthcare professionals in the fight against domestic violence and to promote the identifications of problems. Even if this approach, this recommendation is based on scientific findings, there were difficulties in implementing this recommendation, and this is why the higher authority for health asked us to look into it. So we did it. First, we established a diagnosis. I'm going to speed up because I think we're lagging behind. So we review literature, scientific literature on prevention, including domestic violence. We do documentary review of everything that is carried out by the higher authority for health, but also ad hoc studies. And I say it again because sometimes there are constraints, because they lead us to do interventions in terms of quality detections with different stakeholders. And there's a problem in terms of understanding, and sometimes there are constraints. And I repeat, there are constraints. We have observation work that we could do on public policies. Well, we have more constraints because we're not going to observe what's happening in a medical practice in real situation, for instance. And also, we will translate that and try to interpret that via CONBI, for instance, and behavioral science models, and we'll try to draw up a list of possible solutions, complying with some criteria: impact, ethics, and doability. Human psychology requires from us to be vigilant on some aspects. We'll try to lay out this in a different way, and we see that there are obstacles for GPs, especially because this was where the whole attention focused, and this is why we needed to have aptitudes and skills to dwell into that subject, because there was also lack of knowledge and ignorance of some recommendations. I've found it in many public policy issues. No one should ignore the law. However, we can see how difficult it is to implement it. Issues relating to the knowledge of domestic violence amongst the general population, and also on their mission, their assignments, their role, and also in terms of motivation for some, they would say, and I insist on the reporting part from the GPs. This is actually related to the behavioral science. Some consider that do not have a role to play on that subject. Some are afraid actually to do so. Some do not know the expectations from their patients. Some would be reluctant to talk about that subject, and some do not feel that they have the capacity to act. And then, as for the context, the facilitating aspect of the environment in which they exist, these GPs, these general practitioners, well, when they have a doctor's appointment, the aim has, well, the doctor's appointment has a restricted period of time, and that would not induce to go into that type of investigations. Once this is set up, as said earlier, we'll actually draw an inventory of everything that is feasible, and we'll try to find solutions, specific solutions, that consist in simplifying the life of people. when you have a target behavior, the gist of what you want to do is to facilitate the pathway leading to that behavior that is recommended. First, we need to simplify the recommendations on which we would work, and then set up a prevention questionnaire. In a very synthetic manner, if you want to go more deeply, to dig more deeply into these recommendations, our works have a wonderful quality. They're all published. We are a state public authority that is quite central, but we want to be transparent in our endeavors, and we want knowledge to be transmitted, especially when we face failures. So everything is published, but mainly on that subject, there was a synthetic work with all the recommendations from the HAS that were encapsulated, and we actually had a double-page leaflet that would summarize everything with the formal information to present it in a way that is understandable, clear, and that could be actioned upon. And that would represent some stakes and issues that were of specific interest. The aim is to put forward the idea that we were in a systematic approach, that the aim was to deal with some subjects on the merits, on important subjects, but also to have actionable measures. So, and we needed to raise awareness on that subject. I'm not going to go further on that subject. So we have customization levers. I would urge you to read that report that shows how this double-page leaflet could be beneficial. And then there's something else. I will talk less on that because it was not efficient. We're transparent on our success and failure ratio of our initiatives. That was actually an interview questionnaire aiming at facilitating how to tackle this subject in a doctor's appointment, because a doctor's appointment is not aimed at first to talk about this, but we have a funnel logic here. We try to facilitate how to facilitate the interview, to know how we could actually broach that subject. And it could also be in the waiting room to show that this is a subject that is important to the doctor. We conceived it, we designed it with designers, with the BIT team, but also the other partners that are associated with this experiment. And then we did a randomized control trial. And we worked with 2,000 doctors, the population also. The population group is quite satisfactory in terms of quantity, but sometimes we work on more significant population groups. First of all, the different stages of the assessment. We worked on the assessment protocol. We worked with the insurance sickness authority. That was important because all health stakeholders needed to be involved, because very often they're left aside. Also called for participation because we wanted to target the protocol to make sure that it's more narrow in the implementation. Then we have reminders. We have also a quality relay to make sure that all these experiments are disseminated. And as a wrap-up, the findings are as follows. After all these tools were sent out, we saw that there was a significant progression in the number of screening cases for doctors that were at the heart of this experiment. Of course, that doesn't settle the problem. I want to be very clear. We would intervene only in the perimeter that was suggested to us, but with these few objects, simplification tools, but also an idea that we should be proactive, because often we didn't ask the doctors to look for information on the website of the HAS, but what we did was that we gave them more incentives by handing out our leaflets and by using the insurance, the sickness insurance fund as an intermediary. So this is something that was quite convincing and positive, such that the HAS decided to disseminate it and to scale it up with the insurance sickness fund. and we wanted to have more education, more communication that would be addressed to the general public, but also we wanted to target health professionals, amongst especially the general practitioners. That's one example, but that shows what my real job was all about, namely not the idea that we could have, that with only a few skills and resources we could solve public policy issues that are normally handed out to other actors, but we can find methods that could be efficient. My real life is to be pragmatic, is to see how this behavioral science can be applied in a pragmatic way for the efficiency of public policies, and this is why we have behavioral science. The aim is to make sure that people act up. Thank you. Thank you, Stéphane. Now, as said earlier, for the first session, we should take all the questions for the three speakers at the end. And so we will now welcome Dr. Raphaël Boludnid, who's working at the DL, the Interministerial Department for Housing, and who will talk about the experiment on having a home first.
Je pense qu'il y a une petite erreur, non, ça marche. J'ai pas le... Ça se met pas en fait sur... Ah, bonjour à tous, merci.
Good afternoon, everybody. Thank you very much to Santé, Publique France for this invitation, particularly to give you a talk on this topic. I used to work as a psychiatrist, and it's always been a mystery to me to understand how you can encourage people to change their behaviors. So it was very interesting to apply this to public policies. I'd like also to thank Jennifer for her support in the preparation of this talk. So I'm going to be telling you about the Chez Soi d'abord, the Housing First project, and I'm going to show how we've managed to deliver on some public policies. So I do not have any conflict of interests. So I work for the Interministerial Delegation for Housing and Access to Housing, the DIAL. Let me first present what the Un Chez Soi d'abord is, this Housing First scheme, the results of research, and also I'll be telling you how we've managed to get better results and what the challenges are for the next steps. So, as you can see, the Chez Soi d'abord project is quite simple. It's the so-called staircase model. You have to go through different milestones or steps. Now, at every stage, you learn different things. Often, people have to learn to live with others in emergency shelters or transitional housing, whereas I suppose for most of you, you have to manage yourself or handle your relations with your neighbors. So it's a very simple method. We try to actually skip all these stages. We try to make sure people can have their own home. Also, it's impossible for us to determine in advance whether people will be able to do it or not. So, this scheme is based on 8 principles. I'm not going to go into detail here, but it's interesting to see that these principles also exist in European countries, countries that regard housing as a right and that are based on a philosophy, on the method based on the recovery, and a method which is based on people's personal choices. So we try to adapt as much as possible to where people want to live with whom. So a series of principles, as I was saying, and also something quite important, it provides quick access to housing. Here's a timeline. 2006 is actually when I graduated and when I defended my doctoral thesis. So actually I went through these different milestones. Now, I don't know whether you remember the different social movements and NGOs, Children of Don Quixote. for example, many movements that received a lot of media exposure. And also, we had several examples of psychiatrists going out there on the street to meet homeless people. And we had organizations that started to roam the streets in Marseille to meet people with serious psychiatric conditions. So they would visit them 2 or 3 times, but then people would tell them, that's all very nice, but the priority for me is not to get treatment, it's to get a roof. And actually, at that time, there was an abandoned hotel in Marseille. So a doctor decided to try and test a method that he was not aware that it was actually the housing first method. And it got a lot of publicity, so much so that the then minister in charge of housing, Mrs. Bachelot, went there and realized that it was very effective. And actually, it connects with the previous presentation. So the minister commissioned a report on this issue, and she asked for a state of play of homelessness in France at the time. And they realized that nearly between 40 and 50% of people, of rough sleepers basically, had mental health disorders, whereas it's between 20 and 25% in the general population. But worse still, the life expectancy was lower, 35 years old. Also, it was an opportunity to look at what was done in other countries. In France, we usually tend to try and invent a lot of things in psychiatry and psychiatrics. And it's the first time we actually looked at what other countries did. So that's when the DIAL, my department, was created. So we started some research on a project, Housing First, in New York City. Then a decree was issued by the government. These schemes were replicated. There were also other schemes for highly marginalized people. And we also have versions of these Housing First schemes for young people and in rural areas. And we also have the Logement d'abord, the LDA policy that's been in use since 2017 in quite an effective way. Now, what is this experiment about? It's a randomized experiment in the social, medical, social spheres. So I don't know whether you can realize here, but actually it's very hard because we had to ask social workers to ask to go to people and tell them that they were basically going to be, they would have to draw lots, and maybe they would not get housing. So we originally wanted to work with 800 people, but eventually it was 703. So 350 in the control group and 353 in the Housing First group. What was the main assessment endpoint? The reduction of hospitalization days, secondary endpoints like quality of life, recovery from mental illness, the reduction of addiction, clinical aspects, etc. Also, it was a qualitative study, so we really tried to establish at regional level. So, of course, the individual recovery process, but also the change in professional practices. So that was for the qualitative aspects, and also in the quantitative aspects, we worked on the cost-benefit ratio. So again, I don't think I'm going to read all of it, read out all of this, but we've helped people to move from the street to a home in 28 days on average, which is quite outstanding for those of you who are familiar with this area. And more importantly, we managed to target our target audience, people with severe disorders, for example, bipolar disorders or schizophrenia. We also managed to target people who had been living on the street for quite a long time, 8 years on average. Now, 2 outcomes, this is what we show in many conferences. So you can see on the upper chart that people who have had access to housing. So you can see that it actually works. The orange part is the time spent, or the number of people who stay in their homes. But then there's the issue of acceptance. It's difficult to say to NGOs and players that are already active in the field, what you've done so far is pointless. We're going to revolutionize this field. Now, the second aspect was that of costs. And we've managed to see that some costs were avoided, mainly due to the reduction in the number of hospitalization days. And we've managed to see that it actually offset the overall cost of the scheme, 14,000 euros per individual per annum. Now, the good news is that we've received authorizations for 6 new sites. So we have overall 38 sites. We are rolling this out also in the country, in rural areas, and also with young people. I also wanted to show you this because we've developed another type of scheme which is now nearing the end of its experimental phase. It's also a housing first type project, but for people who want to live in shared housing. Now, what made this possible? How did we manage to scale up? This is a non-exhaustive list, but I wanted to share some of these items with you. First of all, it was an issue that received a lot of media exposure. We heard a lot about people sleeping in tents around the Saint Martin Canal in Paris, so big media exposure. Also, the problem was clearly identified. We knew that a lot of money was invested into this public policy, but that it was ineffective. We had criteria to define what was successful or not. At the beginning, it all started with activists. It was really decisive for the launch of this scheme. And also, I think that at that time, the minister really championed this issue. And it was very helpful in our work. Also, it was not only a quantitative study. We did also a qualitative work on how professional practices can change in this field and how they can be extended to many different aspects of housing support. We did a real stocktake exercise. We really took the time to understand what was at stake, because if you don't identify the problems, it's much more difficult to find solutions. We relied upon international experiences, New York and also Canada, that already had some experiences. Also, a very important criterion, but it has to work, it has to be conclusive, then it's easier to develop further. It also happened at a time where the social system and psychiatry in France were in an identity crisis. So I think this led to a lot of interest in our work. For lots of time, specialists in these areas were a bit wary of us, but now they are really interested in this, particularly for people who are hospitalized in the long term. Also, it's something that's been integrated in public policy for a number of years, and it's now part of recommendations for all mental health plans. It is also something which is recommended at EU level in international recommendations. Also, the central government is strongly in charge. We've exchanged on this with European colleagues, and it's quite unique in France. Because of this central steering from central government, it's quite stable. Also, the fact that it's based on a very tight or close-knit community of experts. Last, I'm not sure the wording is right, but it was really political, but never politicized. It all started in 2009, so we've had Nicolas Sarkozy, President Hollande, President Macron. So there's been some continuity in this public policy. We haven't had any major shifts, and we hope that it was going to stay this way. So it was neither a left nor a right-wing policy, this chez soi d'abord. I'm not saying it's neither left or right or en même temps or at the same time, as President Macron would say. That's not my point. Anyway, now the current challenges. Since 2010, society has changed. Some public services have collapsed. We are in a housing crisis. Now the question today is, how can we evolve the model? How can we adapt everything I've showed you to current challenges? Also, there's a rise in demand. So there's a kind of fatigue or exhaustion. It feels, it looks like it's working, but we have a growing number of homeless people, so it's quite disheartening. Because you think you might be able to contribute to a number of issues, but actually we're not really tackling the root causes here. The limits of the model, I've said that it was successful for 80% of people, but what about the remaining 20%? And finally, societal acceptance. If you want it to be successful, well, you have to ensure that people are ready to live in harmony. It might be stating the obvious, but it's quite important. So the elections, the general elections in the next weeks will be decisive, actually, and will probably determine whether this scheme will be extended. Thank you very much for your attention.
Merci beaucoup, Raphaël. On va accueillir notre...
Thank you. We will now welcome the two speakers for the last third part of this afternoon. We'll have Ivan Point and Emmanuel Laurent from the ANSA, the new agency for active solidarity, and we'll talk about assessing the afterwards.
Merci beaucoup. Merci pour...
Thank you for the invitation. We are delighted to make this presentation. Modestly, I did the 1% that was just like my colleague. It's actually my colleague standing next to me who did most of the job. We are gathered today to present you the latest report that we've just published online, and that sums up and presents the two experiments that were presented earlier on, that consisting in asking ourselves why, when there's so many experiments going on in France and that are rigorously assessed, why there are so little public decisions that stem from them. So, how do these experiments can contribute to the shaping of public policies? What we did was quite original because it was created in 2006, and the aim was to assess the minimum wage, called RSA in French. I thank the organizers for giving me the opportunity to present the study and for helping us to actually carry out said survey. So, to kick off and to understand exactly what we're talking about, we were talking earlier of 200 years. Now, we could go way back to 2015, when some problems were published in New York, when they said that in terms of public policy, government, we can and we have to experiment. And this was actually quite disruptive at the time, a real revolution. Experimenting is not the experiment itself, the experience itself. It's important to remind you of that, because experimenting is a rigorous protocol for utilitarian purposes. That means that we measure the effect of the mechanism that is experimented, but we also control the chain and the phenomenon so as to know where we can act, where there's an area for improvement. Today, it's important to have in mind that experimenting is at a high degree of the hierarchy of norms in our public policy and public law, because it is enshrined in the Constitution as a possibility to waive from some provisions of the Constitution, and we can have experiments. And actually, public authorities are authorized to make experiments, and that gives actually that is quite revolutionary in a way. We assess a lot of things, more and more, so much so that sometimes we forget what we're doing. There were 210 experiments that were carried out over the last 10 years, and there are 3 fields that did not give way to any experiments: taxation, delinquency, and...
En matière d'action publique régalienne. Mais dans les faits...
But actually, what we see is that there's not a lot of assessments that are the subject of decisions or influence relating to the public policy decisions. We'll go back to that. And there's another effect. Public action, well, experiments aims at being instrumental. It needs to serve a purpose, to be mainstreamed. And between 2009 and 2019, we see actually that we're drifting from a semantic point of view on this concept. It's not considered as having to lead to a widespreading and generalization, but rather to knowledge, to deepening of knowledge. We have to be clear on the objective. What do we aim to do? Do we want it to become mainstream, or do we want to test something out? And the two objectives are indeed quite divergent, quite different. One word to say, okay, we work on this objective, namely fight against exclusion and poverty. We've been working on social experimenting, and we've been doing that for 10 years with publications that you see on the screen, and you will find them on our website. To go back to the gist of my presentation, why is there a discrepancy between the number of surveys and the public policies being and the public decisions? Actually, 15% of all experiments that exist, and that are quite numerous, would drive directly public policies. You can see the two brilliant examples that were presented early on. We could be surprised by this low result. However, conversely, we could see that they are very much mentioned by the research scientists. 14% of the publications, it's done by research scientists, and then public decision makers. So there are 4 case studies. 2 of them were presented early on. We have interviews and working groups. How to reconcile timelines, the objectives, that's the heart of our work. There are 3 different groups. There are project leaders, the assessors, research scientists, academics, and then people funding the projects or decision makers. And they have different timelines, they have different time frames, and different cultures in terms of work. The decision maker from the political sphere will impose a different time frame. The research scientists will have a longer time frame with long programs, whereas for the project leader will defend the achievement and the completion of his or her project in a short period of time. Well, we try to formalize all of this. Our study has 3 questions, but we are going to focus on the learning cycle, the second question, so as to trigger your interest. Hello, everyone. Thank you to the organizations. I would like to present the second question. How can experimentation as part of an overall learning cycle can help to remove the obstacles to the trial of players, funder, project leader, and assessor to take the results of evaluations into account? That can depend on a personality and the experiments we're doing. So what we did was to base ourselves on GPAR works, and what we suggested to have a learning cycle and to do it at the beginning of the experiment. So we integrate it into the learning cycle. First, we identify and prioritize the needs, because we need to identify what is at stake, what is the question that we want to answer. And so, jointly, we need to know what is being assessed with all the stakeholders to prioritize their involvement in the project, And as my colleague said also, to conduct experimentation by relying upon research, to draw upon the learnings and findings of past literature so as not to repeat oneself, we have to establish a diagnosis on the capabilities, the capacities, resources, basically. We have to self-diagnose our financial and human resources and to know how we can translate that in public policy. Because it is useless to establish a public policies for which we would not have the necessary means to implement said policies. We have to see the potential of social acceptability and understand the social and political context in which it is enshrined. For the moment, it would be quite complicated. However, it's still doable. That means that we could not prevent the rolling out of the policy, but we have to anticipate how research can be factored into the public policy. So I would like to go back to the experimentation of screening on domestic violence amongst the GPs. This was a diagnosis work to find a solution that would be the most straightforward one, the most doable one, and we would eradicate solutions that would not be realistic and feasible. So, we should first take into account the political and social context, as was said by the earlier speaker when he talked about having a home first. So we need to have a coordination of human resources. That seems obvious, but we need to coordinate an experimentation. So we need to reconcile the time frames that we mentioned earlier. We need to integrate fully the experimentation nature of what we're doing. As Pascal Gandy, who was the coordinator of the project at the time of the experimentation, she said that to reconcile the time frames, she was on the phone with the funders every day to keep them appraised of the situation, and so that we could actually find a compromise between the need for research and the achievement and the completion of the project. It's important to deploy, to have an experimentation that is consistent, and this is why we need to have a good assessment. It's not necessary just to document whether it works or not, but why it works, in which circumstances it works. So we need to have quality criteria to detail out the protocol that will be rolled out, to have a detail also of the heterogeneous nature of the impact, because we want to give details as to the program. We need a study of costs, so as to compare two existing projects and which work. We need to know the one that we need to identify which one is less costly. Even if the program costs a lot of money, it could be compensated by all the costs that it would save as a domino effect, and progressively we could have a generalization, a scaling up to all regions, so we could experiment the project on different territories in different contexts. And then we have to disseminate the conclusions, the findings of the experimentation. Why? Well, because the experimentation was done with 3 players, namely the project leaders, the funders, and the assessors, and the aim is for this to benefit to other public authorities. For instance, if it's done in a département, it should be used by the parliament when enacting a law, when adopting a law, for instance. We know that public decision makers do not have a lot of time to read literature and experimentations that underpin said publication. So we need to show it in a more synthetic manner to make sure that they can read it swiftly. We can also draft it in a way so as to have it accessible for the general public in the run-of-the-mill press, the media, but we need to make sure also that general public can take ownership of this, so that there's a stronger commitment of stakeholders that would be directly involved in events, in workshops, in training sessions, to make sure that they take ownership of the findings and the learnings. And then, beyond the dissemination of this, we have to have an institutionalization of the findings, because we are here in an experiment field. We suggest an experimentation. Based upon that, we would produce and generate knowledge. Then we have public actors that would rely upon the findings of said experimentation. And what is quite interesting is that all these tools, everything that enables centralization of data worldwide, we've already worked on the report, the worldwide centers. And these wet works centers enable, well, they help us synthesize and pool the outcomes of experimentations, but also to make it more accessible to the general public. It's easier to understand, and we can also select and opt for the information that is most appropriate and relevant for their own public policies. There are other examples that are being designed. There's also the base of evidence for health public policies. There's also the higher audit authority, not only for experimentations that took place over the last years. And then I would like to give you our 10 recommendations that are set out in our report. You can see that I tried to make a summary of it. The first one is to favor hybrid and complementary methods to make sure that we can answer to the widest possible amount of questions. Then to try to involve all stakeholders as soon as we design the experimentation, including those that are directly affected by the mechanism, the project. Then we have to anticipate the hurdles, the obstacles to experimentation and the potential for social and political acceptability from the outset. We have to dedicate substantial human and financial resources to coordinating the trial. The next one is to train decision makers and promoters to mobilize research. The aim is not to train the new researchers, because you don't become a researcher overnight. But the idea is to know where we have to mobilize research, when we can, and which political issues could find an answer by which type of research. We have to draw up precise and operational recommendations to avoid confusion. And in the assessment of this experimentation, we have to propose synthesized formats for disseminating results and developing complementary dissemination models. This disseminating time is one of the most important conclusions. It should be included in the call for project as something that is mandatory, because often we were told that they wanted to disseminate their results, but they couldn't because they did not have the financial means to do so. We also need a scientific mediation to make sure that it is disseminated, that the recommendations are disseminated, and we have to have a public institutionalization and centralization of the process for developing and using research and evidence. Thank you. Thank you for your attention, and the report is available, has been available since yesterday. Thank you. Thank you to all of you. Oh my God, you are right on time.
J'invite tous nos orateurs.
I'd like all our speakers to join us on stage now for Q&A. So it might be a bit shorter than expected, but still, let's have Q&A because it was extremely rich and interesting. I'm sure you do have questions also on the chat. So maybe we can first take questions from people in the auditorium. Do not hesitate to raise your hand if you have questions for our speakers. Thank you. Of course. Well, then I'm going to start with the questions in the chat. There's one question which I think is a bit tricky, but quite interesting. I just wanted to warn you. What are the available levers when decision makers who are also funders commission an experimentation whilst perfectly knowing what they want? Interesting but challenging. Who'd like to give it a go? Well, I'm in a conflict of interest situation here. Same for me, same for me. No, go on, please. Well, you can't all be in a conflict of interest. Okay, let's take a step back on behavioral sciences. Let's think about capacities, motivations, etc. These decision makers must often have more cognitive biases than the citizens for whom they ask us to change behaviors. So without that level, or in other level of public governance, somehow they must be involved. But there are many reasons not to embark upon experimentation. So either they will do something, even with biases, or won't do anything. So I think it's important to try and align values. We need to find commonalities between agendas. You want to make sure that the project, that they can actually embrace them and own them. And you have to make sure that schemes actually meet other objectives. And it's the same when, for example, you address policy issues with long-term implications, for example, the environmental transition. It's quite difficult to get people interested in environmental transition. There's this, what we call this temporal myopia, short-sightedness. People don't always see the advantages in the near term. So if you want to deal with this, you can actually include intermediate or medium-term things related, for example, to spending power, etc., or the cost of living. And again, it's not only about top-level decision makers, it's also people in the field who do not always have these priorities as inherent priorities. And then people do not describe the reality with the same words. So I think sometimes you need to be a bit secretive about your actual agenda. Okay, did you want to pick up on that? Well, I think there are three ways to answer this. Do you realize this when you start the experimentation? When you start an experiment, for example, on social policy, you may realize that one department or county is less receptive to experiments. So it's better to start in the region or the county where you're going to start the experimentation. Second, as Stéphane was saying, it's very important to convince decision makers, and that's why you need to develop several research methods. If you cannot convince decision makers because of the costs, you can, for example, with the potential outcome. Third, if you don't have the right region, if you have no way of convincing decision makers, it's fine. Just do the experiment, and maybe that will be a way of influencing other decision makers in a different term. You know, these experimentations are also designed with the long-term view of things. I think there's a risk. There's a risk that the experimentation may be used to someone's advantage. They might think, the decision makers might think, okay, this is a sandbox, just, you know, have fun, do your experiments. And I'll see, do you catch my drift, says the speaker. I think it's very important here to be intellectually honest. And that's what we learn in academia. We have to remember that irrespective of political principles, objectives, we will follow the same protocol. Yes, and there's another aspect, and again, it's not a winning formula. Okay, I don't have a magic wand. If I had one, I would already have used it. Transparency. That is designing specific formats. You might start experimentations that will have a higher media exposure. So it's quite simple. Sometimes it's easier. For example, if you show a decision maker a control group behind a window in an experiment center, instead of just showing results on a document in a report. Well, I think it's important to look at research not only in terms of results, but also in terms of the process. When people take part in research and experiments, it starts some dynamics, some processes at regional level. You don't start an experiment with the certainty that it's going to work. We know that the path, the process is very important. And actually, some new dynamics may emerge during the experiment. Thank you very much. It was a tricky question indeed, but we have received very interesting and rich answers. Are there any questions in the auditorium on the different talks, all relative to what has been said? Yes. We have a question there.
Merci beaucoup.
Thank you very much.
Oui, bonjour. Donc, je suis Dominique.
Hello, my name is Dominique Janet. I work at the Department of Prevention and Health Promotion in the Santé publique France. Thank you very much for your presentations. They were very interesting indeed. So, comment and a question. You showed that very few experiments translated into proper implementation in public policies at this point. And then you presented a kind of learning cycle. And you said that, that right from the start, you had to determine whether the experiment could then be brought into general use further down the line. Now, I think there's a difficulty here. To do the experiment, you need to have the right conditions. You need to have qualified professionals who can train, something which is not easy to replicate when you go on the when you go industrial, basically, when you extend it to a larger scale. So do you have any ideas as to what can be done when you bring the experiment into general use? Well, I can answer this because that's my job actually at the DL, about making sure that the replication of the intervention model is done properly. So we've adapted a so-called loyalty scale. So I go out there to sites every 2 years. I spend some time with local teams, and I tell them about a number of things. It's not about telling them you're doing right or not, or you're loyal to the model. No, we're trying to explain to them why they are actually in line with the model or not. And again, as I was saying, it's quite unique to have this central coordination in a country in Europe. To me, it's the main guarantee of success. So you need to have clear tools to ensure loyalty to the system and some steering at local level. Yes, it's interesting. It's one of the recommendations of our report. That is, making sure that researchers and assessors are still on board after the assessment when the process is replicated. It doesn't mean that you're going to re-establish such a time-consuming protocol, but that you can keep track of effects to see whether regional replications, local replications are in line with the original concept. And also, it's very important also to make sure that professionals who are involved in the replication are properly engaged, to make sure that this extension occurs seamlessly. Well, let me answer your question with another question, because there's something I don't know, but maybe other people do. Sometimes, when you scale up, it actually changes the protocol. So something that may actually work at, let's say, 100 or 100 scale will not work at 1000 scale. So what are the determinants that explain this? Why does it work in one case and not in the other? And I have to be humble here. I don't know the answer. I don't have any model that could explain this. Why do I have to answer this? Okay, I don't have any one-size-fits-all or theoretical answer, but for example, we did some work on the repairability index. We were tasked with doing this by the Ministry of the Environment. We had to apply the European directive on the circular economy, so to encourage consumers to buy products that are easier to repair. So we had several experimental stages. At the beginning, they were more qualitative. This then led to a more exploratory phase with about 2,000 people at the time. Then it became more quantitative. It was less self-reported. We conducted tests with about 150,000 people, and this led to the current repairability index. And then we did some double checks in real-life conditions on a large network, but using real purchasing data. So we tried to establish some correlations between purchasing data and the introduction of the repairability index. So I think, have fun with the different methodologies. You need to try and test things. Start with something quantitative and gradually move towards something qualitative. Thank you very much. I suppose we can take one last question. And sorry to remote participants for all the questions in the chat that we cannot unfortunately answer. Yes, well, lots of pressure. That's the last question. I work for the Science Partners Cooperative. It seems that you have developed a very interesting collective expertise in terms of participative democracy. I just keep thinking that lots of people have ideas to make things better. You said that it all started from activists campaigning for this. So when you start your experiments, is it mainly because the government asks you to do this? Because your line ministry asked you to do that? Or your line agency? Or are there any other stakeholders that can start an initiative? For example, they can tell you about an idea they had. Anyone who wants to experiment, and provided people have some financial means, we can support them. There's an example we reviewed as a case study in our report to diversify things. It's the Énergie Jeune program. It's a scheme to develop the psychosocial skills of high school students to help them better perform academically. It was started by an NGO that got in touch with a research team, which then took on the project. And now there's a second experiment to extend this to the whole French school system. But originally, it was all started by an NGO about 15 years ago, I think. Yes, and we have a number of experiments at a very small level with very small NGOs that have a very little budget that want to test things out. So it's perfectly feasible. It doesn't require a huge scientific protocol, and we can adjust depending on needs and on the demand. Well, it can come from grassroots level, but it has to be a priority as well for the government. For example, in employment, when we started with Housing First, we realized that people also wanted to get a job. So we developed similar methods. So there's Working First, and since 2014 we've tried to develop this. And unfortunately, it didn't really catch on. But since 2017 and 18, we have seen that everything related to work, to people with disabilities or people facing hardship, all this is back on the agenda. But you need to make sure that it's actually a political priority of the day. Now, I have two things to say. I work on the government's priority policies, so I have to stay in line. And sometimes I work with the DL, but sometimes you can align your work with other needs that were expressed at local level. But also, sometimes we really promote a number of topics. We had a topic, particularly protecting consumers. Like for any public policy, it's essential to understand behaviors, to experiment and to make measurements, but there are also economic players, commercial players who are quite familiar with these topics. So the government also has to be expert in this. But of course, for all these projects, you need to go out there in the field, you need to experiment. There are many different stakeholders. So public agencies or administrations that ask us to do this work already have coalitions of stakeholders. And one last thing, my job is to make sure that all this can become possible. My dream is to have a kind of ecosystem with public research, etc. But the legal reality makes this difficult, which is why we had to issue an invitation to tender at ministerial level, and this makes it possible for government administrations to take part. Again, you can start coalitions of different stakeholders. We also have the so-called regional innovation laboratories that can also start this type of experiments at citizen level. So there are opportunities out there, but of course there are some requirements on the part of the central government. Thank you very much. Well, it is quite frustrating for me, but it falls upon me to end this Q&A. Thank you very much again for the quality of your answers. And we've had a lot of messages in the chat where people have been thanking you for the quality of your presentations. I can see fascinating here in capital letters. I suppose a lot of suffering as well.
So we will wrap up now with two speakers that are very reputed and who will offer their words of conclusion. We have the first speaker coming up, Mr. François Beck. François, you're the first.
Comme vous voulez tous les deux, comme vous préférez.
Bonjour, ça marche?
Hello. Hello, everyone. I'm delighted to be here. I really loved what I heard this afternoon, and I want to thank all the speakers, but also the organizers of this session. It was a great pleasure to attend this session. I'm in charge of prevention and public health at Santé Publique France. We are a group of 100 people, so I represent 1% of the work that is being done by this department. It's a very skilled department, and in terms of behavioral science, to induce change and bring about consistent public policies, I would say that it's very interesting. As to the purpose of Santé Publique first, the aim is to target all populations in France, and so this is why we do health promotion and prevention measures. We try to be efficient to reach a good health condition amongst all the French population. What you have seen is and understood is the necessity for these actions to contribute to curb social disparities, not to deteriorate them at the least. This is our daily work. We have an arsenal of tools such as marketing campaigns, grassroots actions that we can roll out, partnerships with grassroots stakeholders that would sometimes be a continuum of our actions or disseminate them with vulnerable groups. And we do advocacy as well on the evolution of regulation when we deem that it is important for public health purposes. You've seen different examples. This is built around a complex modeling system. And in this modeling, we have levers and hurdles, and we try to act upon that in the most efficient manner. Behind this, what we try to do is make sure that everything we implement or everything that we try to promote will work out well as we hoped it to be. So what we're looking for, and that was what Pierre reminded us in the introduction, is not to fight. It's very, of course, it's very important. It's not to fight against intuition, but to try to find this intuition and then to expose it to reality and to have it field tested in a way. So what do we do with this? David Elpa reminded us of that yesterday in the plenary session. Irrespective of the name we give it, the aim is to experiment and test it. And this is where we stand today. This is what we're trying to do as well on a daily basis at Santé Publique France. We do literature review. We test out different creative tracks to try to find the best and the most promising venue. We try to make experimentations to try to see if the behaviors have changed or if a social norm could have changed, if representations could have changed, because this is part of a path that we need to take to change behaviors. We have a co-construction work with our partners, and we need to pay constant attention to health literacy. And these are powerful weapons to fight against social disparities, and this should be at the heart of what we do. We're starting to work on prevention, and I'll let Mr. Bardou talk about it after me. I would like to thank the French BIT office. We've been working with them for quite some time, quite some years. This collaboration allows us to go further with all the tools that are presented. It helps us to flesh out our structure, to give us self-confidence, and to carry on with our endeavors. So it is very interesting for us. I would like to go back to the presentation on ATBR. It was interesting, as all the others, because it could show how, when we have an initial objective, which is quite interesting, which is laudable, and all this work can allow us to rethink everything and to scale up our action on ATBR and give ourselves new objectives in the framework of different stages that will be reached one after the other to reach an ultimate goal. I'm not going to talk about all the examples because it was a real success and it was very fruitful, but I would like to go back to general takeaway messages that have transcended today's sessions, but also yesterday's session, and especially yesterday afternoon. We talked about the ethical dilemma. That's very important when we broach the behavioral change issue. What we do with Santé Publique France, where we do not turn our back to ethical issues, we try to tackle this head on. What we want to do also, well, I'm not going to get into the details, but we try to ask ourselves the question of the efficiency of what we do. When we act, when we have an action and we try to make sure that it works, we'll have a lot of impact that may be positive or harmful, so we have to measure everything. And there's always this matter of how our intervention will act on social disparities, inequalities, and all our surveys and studies will try to assess this in a systematic way. To go back to an example, a tool that we've been using quite a lot, that eats up a lot of our budget, that's social marketing. We can ask ourselves the question, the ethical question. it is part of parcel of a universe that is marked by industrial marketing that will have harmful consequences on health behaviors. And so this ethical question should be asked in this framework, against this backdrop. This is why we use this tool as a weapon against industrial marketing that we find not suitable. There's also a controversy about epidemiology between this social science and behavioral science. I thought that the landscape was evolving for some years now, and there's no position that is not reconcilable between the two. Stakeholders could allow these two realms to meet with one another. I would mention a few levers. One of them is to factor in the expectations, the grassroots agents that are involved. This is something that is fundamental. And you've seen it in the presentation. We can take that into account. We have to continue doing so. The transferability, the adaptation of international interventions that are efficient and to transpose them into local context, working with local stakeholders, mixed projects. We refer to quality projects. That's a tool that we use in behavioral science, and this is very important. And more generally, an analysis, also some subtlety in the analysis. This is something that is quite important. And I think that the different presentations that were given this afternoon are real advocacy for the use of behavioral science for better health of citizens. Mr. Badu, you have the floor. Thank you. I will try to be brief. I'm a clinician, physician, and my job is all about assessments. I thought that all the presentations were very interesting. Assessment is important. And I make a distinction between experimentation and assessment. Policies are guided by assessments, ex ante, but we can also, and we have to take into account this culture of assessment. For instance, for first housing, this came from an initiative from someone who actually decided to squat a hotel. Domestic abuse. This started from someone creating a house, a haven for women who have suffered from domestic abuse. So we need to give ourselves the means to assess this. When we have a public policy that is complex, we have to try to build assessment tools, because assessment relies on judgment criteria. What are we going to keep as takeaway indicators? That's important. When we looked into the first consumption rooms, we needed to have assessment. And this assessment we need to know to whom it is addressed for risk management. But at the same time, there's an environment. There are people that would be against such project. And we need to understand, and this is why a mixed approach is important. We need to have quality. What are your fears? If we have a room that is dedicated to drug abuse, drug users, that will be a problem, and that will be feared by others, and it could inspire fear. So, for instance, for this haven for ladies who have suffered from domestic violence, we could then say, if there's no assessment, that we work not well. So the aim is to understand why we have this assessment, why we want to find the area for improvement. Public policies can be decided because as a policy decision maker, I want to create this, because it requires a lot of time. When the first the first house for women suffering from domestic violence was opened, we were asked for a report by Mrs. Touraine in 2017. We needed to build KPIs, and then we started in 2024, 7 years later, and to assess this, it's a budget of 500,000 euros. And that's this issue. If we wait too long to launch the policy, to move forward with the decision, then it will be very long. When we do have public health consumption, it's often multi-pronged. It's complex. If it works, or if it doesn't work, we need to see what the obstacle is, why the policy didn't work. There's a message that is very optimistic in what was said today. There's a lot of assessments being done. And we have indicators that show what works and what doesn't work, and there's not a lot of public policies based upon assessments. We assess a lot, but we don't use these assessments very much. I don't have an answer on why it is the case, but you were all convinced that we can experiment, that we have to experiment, we can assess, and we can all gain from it in terms of political efficiency, of being able to match the public policies and the needs in terms of public health. And the essential element is that we don't design and shape public health policies without the involvement of citizens. And an important point also, and crucial, is that on this behavioral change science, we have to pay attention that we say, okay, we know what's good for you, and we should be able to argue. You all know this 5 fruit and vegetables a day. Do you know what is the scientific evidence that underpins this argument? We have to have the capacity to argue, to validate. When we say 5 fruit and vegetables a day, what about if we eat 4 or 3.5 fruit and vegetable? So to wrap up, assessment is complex. Assessment of public policies is complex because it inquires a lot of factors. It depends on the context very much. It's very much context dependent. And it relies on data coming from literature, from foreign countries, but it is important to question ourselves as to when we set up a policy in our country or in another region with a different social, geographical, economic context, will that change? We need to have the capacity to understand all the factors that would lead to failure or success. If I do a medicine trial, if the patient is not cured, it may be because the treatment didn't work or because the patient didn't take the medicine as he or she should have. So hats off to you for your communications. Thank you, Santé Publique France, for having taken the time to organize these 2 sessions on behavioral change science, which is a wonderful and riveting subject. Thank you. Thank you, François. Thank you, Marc, for this closing remarks. I see that the room is still full, which is a scientific proof of all the interest triggered by our discussions this afternoon. Thank you to all the speakers, and above all, thank you and congratulations. I should not forget that. Thank you to the organizers of this session. Congratulations to you.